So today we're talking about diabetes. Diabetes, unfortunately, has become very common due to the obesity epidemic in South Africa as well as the rest of the world. If we look at diabetes, it is actually the complications that are so scary. We would pay at claim stage for the complications. So let's look at the various complications. They are divided into macrovascular and microvascular complications. On the macro side, it is heart attacks, strokes, and peripheral arterial or vascular disease. On the microvascular side, it's all the small arteries, like in the back of the eye, the retinopathy, or the neuropathy, the small vessels that supply the nerves itself, and then the small vessels in the kidneys. So let's just run through these various complications. The pathology is actually the same. Diabetes is a systemic vasculopathy, a systemic disease of the blood vessels. It is seen as an endocrine disease, but the pathology is actually in all the blood vessels. So we look at atherosclerosis. Atherosclerosis starts as plaque, growing and obliterating the lumen of various blood vessels. If it happens in the heart, it's called a heart attack. If it happens in the brain, it's called a stroke. If it happens in the arteries supplying the legs, it's called peripheral vascular or peripheral arterial disease. If diabetes damages the small arteries in the back of the eye, it damages the retinal artery and the small branches, and it's called diabetic retinopathy. If it attacks and damages the kidney, it's called nephropathy. And if it is damaging the small arteries supplying the nerves, it is called neuropathy. So heart attack, obstruction of any of the coronary arteries will lead to death of the heart muscle with all its complications. Stroke, various causes of stroke, but the most common one is a thrombosis in the artery of the brain, one of the big arteries of the brain. Thrombosis, which is a clot in the artery, disrupting the blood supply to that part of the brain. If the brain is not supplied with blood and oxygen and glucose, that part of the brain will die, and that is what is a stroke. We can see in our illustration that there is one area that's totally blocked off, but the area around this has also got decreased perfusion. Diabetes can also cause peripheral arterial disease, where there's plaque in the artery, mainly going down the leg, and that will cause peripheral ischemic disease or peripheral vascular disease or peripheral arterial disease. Typical symptoms, if somebody walks after a little while, they need to stop and wait till the blood flow is restored, and then they can walk again. Diabetic retinopathy, we have to look at the images. Eventually, it can cause total blindness. In the beginning, there would be acuity problems, that the picture or the image is not as sharp as it is, and then also blocking out of certain parts of the visual field. If we look at claims, diabetes would normally be paid once there is end organ damage, for example, blindness or visual acuity impairment. Diabetic neuropathy is where the small vessels supplying the nerves are damaged. And we see that very often in the diabetic foot. That is actually a combination of poor circulation, but also poor circulation to the nerves and superimposed infection. And that can lead to gangrene and amputation, which is also covered under the critical illness or the disability benefits. In the kidney, there are very small blood vessels, arteries supplying the glomerulus. If these little arteries are damaged, it gives rise to nephropathy, where you find that there is protein in the urine, glucose in the urine, and unfortunately diabetes is now the #1 cause of end-stage kidney failure. If we look at diabetes from an underwriting point of view, we have to be very careful because it's almost never just a raised glucose. There are always other factors. So we have to look at the control of the diabetes, and therefore we check the HbA1c, which is like a 3-month marker for diabetes control related to the glucose. Then very important, the diabetic should have lower lipids, even lower lipids than normal people. Blood pressure, very important to control the blood pressure. The targets for diabetics, much lower than for people without diabetes. Diabetics should not smoke at all. So smoking in a diabetic is not just applying smoker rates. It is a much higher risk. Fortunately, our reassurers have wonderful diabetic calculators in their manuals, and it's quite easy to plug in various factors, the BMI, the lipids, the HbA1c, if there's protein in the urine, if he's a smoker, non-smoker, the duration of diabetes, and so on. And that makes underwriting diabetics much easier. Traditionally, it was very difficult to grant extra benefits for diabetes, such as critical illness and capital disability and income replacement. But it is possible to rate somebody for those benefits and to offer the benefits if the control is very good and if there is a track record that the control is so good. And then you have to look at the big picture. You can't just take glycemic control. You have to take all the risk factors into account.